Hi, my name is Mercy. I'm the Tissue Viability Specialist Nurse Lead for Merton. I've been involved in this project with the district nurses.
Hi, I'm Esther. I'm one of the Clinical Operations Manager for Merton. I'm looking after the two teams that are involved with the Leg Ulcer project.
Hi, I'm Lisa Powell. I'm Clinical Services Manager in Central London Community Healthcare, and I manage Merton Population Health, which covers the community nursing team. So I've been working with the Health Innovation Network and the community nursing teams on this project, introducing the National Wound Care Strategy for Lower Limb Wounds into the community nursing teams. And we started with a pilot of 2 teams, so a population of about 45,000 patients, and now we've increased to nearly 70,000 patients. And we started the project around March last year, so we're coming up to the first year of the project.
Our aims were to reduce unwarranted variations with managing lower limb wounds and implementing the National Wound Care Strategy for the lower limb wounds. Our caseload had increased significantly during COVID, so we're looking at to improve our healing rates, reducing any unnecessary patient visits, and improve sustainability to reduce waste and costs. We also were looking at reducing harm to patients by giving them the treatment that they require at the right time. So the biggest challenge we have was training staff and getting all their competencies signed off, and also having those staff that have been trained to build more confidence, because staff were reluctant to start patients on compression without any Doppler, because historically they've always known that they had to undertake an ABPI or Doppler sounds, etc., before they commence any compression therapy. So also the other challenge is to do with podiatry involvement with the pathway. As COCH podiatrists in our area here in Merton, they currently do not do any compression therapy. So we've been finding that full assessments for patients with lower limbs are now being undertaken within 2 weeks, which is quite an achievement, because historically they used to take weeks and weeks, if not months, obviously. So patients are getting compression therapy from the first visit if there are no red flags now, giving staff a clear guideline on timing with assessment and treatment, which improve their confidence and reassurance with putting patients in compression therapy without a Doppler. Obviously, once they've ruled out those red flags, is one of our significant achievements. And we are also seeing reduction in our case loads, rather, I should say.
So I think if we'd have started earlier with our training of the nurses, so doing the updated wound training and signing them off on their competencies, because that, I suppose, takes a little longer than you anticipate. We might have then been able to include more teams into the pilot earlier on in the project. So we just started with the 2, and then we've only just introduced the 3rd one now, looking at introducing the next one in April. And it took quite a lot of planning and process mapping, looking at what was currently in place and then what we needed to put in place and working out where the gaps were. So I suppose realising the amount of time needed for all of these steps, we probably also might have approached our data team a little sooner to look at how we could collect the data, because there's certain metrics that we needed to collect and we wanted to collect, but using our computer system you could only do so much of that. So some of it's a manual count, which is obviously quite time consuming. So I think support from the Health Innovation Network was really helpful with the project. Sort of the project meetings that we had, ensuring that things were on the right track. We had a really useful workshop for implementation, looking at a tracker, so we could sort of plan the timelines of everything, which was really useful. And as well as initially at the beginning, they helped us with reviewing the process maps, and so, like I said, identifying the gaps and where we needed to put things in place and how we were going to go about that. I think really the workshop that we had, and using the implementation tracker was the most useful tool, and then we could use that as a clear timeline, and we also then used that when we were in other meetings with our trust, to update on how the project was going, and we could sort of give everyone some clear information on where we were expecting to be then next month, and so on.
So for our service, we plan to roll out to the remaining community teams by September 2024. That's our aim, that everyone will be on the pathway. And we are also thinking of offering trainings to practice nurses to work with the primary care. And this project also feeds into a trust-wide leg ulcer working group. So we are working for this pathway to be a standard for the whole trust, and to standardize the training for the trust management of lower leg wounds. So for top 3 tips for those who wants to embark on this journey is to do a workshop for the implementation tracker to identify barriers early and to identify who will lead on the project and if there's any actions that need to happen. And second one is to have staff trained prior to the launch or prior to starting the project, and allow enough time for staff training and for competency assessment. Just establish clear timelines. And the third one is to work out the data collection process, because what we did it manually because the clinical systems was not set up. So if you can do that ahead of time, so you can have an automated counting of your data and see what is available within your clinical system.